My name is Shaji Kumar. I'm an associate professor in medicine in the division of hematology at Mayo Clinic in Rochester. The mSMART or the Mayo myeloma stratification and risk adapted therapy is a consensus guideline that the myeloma experts at Mayo Clinic have put together to help guide treatment of multiple myeloma. These guidelines were initially introduced a couple of years ago and since then has been extensively used. We have been updating these guidelines as new data becomes available. Most recently, we have updated these guidelines based on the data that have become available in the past year, and this is published in the Mayo Clinic Proceedings December issue. The purpose of these guidelines is to assimilate the available data to provide some sort of guidance to treating physicians across the country and the rest of the world. The multiple myeloma is a very heterogeneous disease, and the outcome of patients with myeloma is very different depending upon the particular characteristics they present with, especially the presence of cytogenetic abnormalities in these plasma cells. A lot of things have changed in the treatment arena of multiple myeloma in the past decade. Most importantly, several new drugs have been introduced to take care of patients with myeloma, and many of these drugs have been very effective in treating this disease. Even though the disease still remains incurable with the current treatments, a lot of progress has been made in terms of improving the survival of patients with multiple myeloma. Now, this has come about as a result of multiple factors, most important of which are the more widespread use of stem cell transplant in the eligible patients, the use of the new drugs as I just mentioned, and finally a better supportive care of patients with multiple myeloma. To summarize, the current mSMART guidelines gives a approach to the management of patients with multiple myeloma, starting from the diagnosis all the way to their treatment. The diagnostic tools that have become available for multiple myeloma over and above what existed 10 years ago includes the serum-free light chain assay, which has become a more widespread in terms of its use. More importantly, the risk stratification of multiple myeloma has changed quite a bit in the past few years. This has come about as a result of more widespread use of FISH testing, which have allowed us to identify genetic abnormalities in the majority of patients with multiple myeloma, which was not feasible with the conventional cytogenetic testing that we used to do before. Now, availability of the FISH testing and a wealth of data that have come out from different centers looking at the impact of these cytogenetic abnormalities have allowed us to formulate a strategy for risk adaptive therapy for patients with myeloma. So the mSMART guidelines allow us to stratify patients with myeloma into a standard risk group and a high risk group based on presence of certain cytogenetic abnormalities, especially the hypodiploidy and deletion of chromosome 13 on conventional cytogenetic analysis, or presence of translocations involving the chromosome 14 such as the T414 and the T1416, as well as deletion of 17 chromosome P, which is again associated with the loss of the tumor suppressor gene P53. And finally, the rate of proliferation of plasma cells as estimated by the plasma cell labeling index. All these together allows us to group these patients into standard risk or high risk. Patients who have these abnormalities are considered as high risk, and these patients tend to have more aggressive disease with very short response to treatment, and these patients rapidly become resistant to the available treatments. So we feel that it's justified to adapt the therapy for patients with multiple myeloma based on their risk stratification. Based on these results, we feel that patients with high-risk multiple myeloma should have treatment regimens that include bortezomib the proteasome inhibitor that has been shown to overcome at least the prognostic effect of deletion of chromosome 13 or the translocation for 14 in multiple studies. In addition, the mSMART guidelines also broadly groups patients who are younger, who are transplant eligible, and patients who are older or otherwise transplant ineligible. Again, we feel based on the available data that patients who are transplant eligible should undergo therapy with either lenalidomide dexamethasone or a bortezomib dexamethasone combination if they are standard risk, or a bortezomib containing regimen if they are high risk. And following this, we should go ahead and collect the stem cells after 4 to 6 cycles of treatment. After that, in the standard risk patients, our recommendation is to let the patients choose between an early stem cell transplant, meaning they go to transplant right away, or a delayed stem cell transplant where they can continue with the lenalidomide or dexamethasone and then think about stem cell transplant when this treatment fails. Our experience has shown that either of these approaches are comparable, again similar to what has been described prior to the introduction of these new drugs. In contrast, in patients with high-risk disease, we feel that these patients should be started on a bortezomib containing regimen, and then their stem cells should be collected, and if they have not obtained a complete response from their initial therapy, should be considered for an early stem cell transplant. We also feel that patients who have high-risk myeloma should continue with some form of maintenance therapy to try and get to the maximum depth of response as possible, and also to try and keep them there, because we feel that these patients have a higher risk of developing resistance to treatment. So getting to a point where there are few myeloma cells left behind is likely to be of benefit for them. Whereas in the older patients, based on the available phase 3 trial results, we think these patients, if they are standard risk, can be treated with melphalan, prednisone and thalidomide, since the preponderance of the data at this point, based on 5 different randomized trials, suggests that there is a benefit to using melphalan, prednisone, thalidomide over melphalan, prednisone. In contrast, again, in patients with high-risk disease, we feel additional bortezomib will bring about some additional benefit. From a patient standpoint, these guidelines serves to highlight the fact that everyone does not have the same type of myeloma. So it's important for patients to bring up the question of getting additional testing, such as the cytogenetics and FISH testing, at the time the diagnosis is made, since this can impact the way they should be treated. So again, myeloma is a very fast-moving field at this time, and there are a lot of exciting things on the horizon. The most important aspects about the myeloma treatment, again, is to better understand the biology underlying the heterogeneity of this disease. While genetic abnormalities clearly play a major role, that alone do not account for all the differences that we see across the patients. So we still need to find out additional characteristics about disease that may help us choose the treatments better. The second major advance in the coming years will be in the introduction of the new treatments. There are several new drugs that are going through clinical trials, including new versions of lenalidomide as well as other proteasome inhibitors. In addition, there are new classes of drugs that are also being tested, which are likely to be beneficial for patients. So I think in the next few years, we are going to see a lot more drugs being available for treatment of myeloma, which will allow us to make this disease into more of a chronic disease, even though it may not be curable yet. But eventually, we hope that the disease will become curable with the new developments that come along.
We hope you benefited from this presentation based on the content of Mayo Clinic Proceedings. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you're interested in more information about Mayo Clinic Proceedings, visit our website at www.mayoclinicproceedings.org. There you will find additional videos on our YouTube channel, and you can follow us on Twitter. For more information on healthcare at Mayo Clinic, please visit www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.